I want people to be able to be their own advocates, because for me, it took like changing a job, really focusing on work-life balance, getting a regular schedule, really decreasing that sympathetic overdrive I was in. I mean, I was like in fight or flight, if you will, like 24/7. I could not calm down. I was like an insane person. And I really needed to be away for it to work for me. Not everybody needs that, but this is 100% the right journey for me. Things evolve as they're meant to evolve is kind of my philosophy. So I learned a lot. I feel incredibly blessed to have had the career I had. I'm incredibly blessed to have had the opportunities that I have. And I'm just going forward being like, listen, at the end of this life, I want to feel like I made an impact. And for me, I still enjoy one-on-one patient care, but if I can impact thousands or hundreds of thousands or millions of people by educating them, dude, that's a win. That's a win. Isn't it like refreshing? And the conversations that you have, sometimes you actually end up learning things about yourself. Sometimes things like, at least in my neck of the woods with doing sleep, like I always prided myself in feeling like I was a really good sleep doc. I was like, I really do a bang up job. Like I'm proud of myself. Like I put out quality work and I feel confident about that. And then I started talking to so many different people who are either in academics or just people who are in private practice, but are academically minded like myself in sleep. And I'm like, boom, my world has just expanded. The amount of reading I'm doing, going to conferences, getting different insights into how people practice, what's the newest and greatest, and feeling confident with the newest and greatest things like in medications, particularly in rare disease like narcolepsy and IH, where I really had, I've always enjoyed taking care of those patients, but because it's rare, you kind of have limited exposure. It's sort of that unicorn that you find that you can really, evolve treatment for them. But at the same time, it's like, I can treat you, but there's so many new things coming down the pike, and you want to feel confident and comfortable about what you're doing and really kind of know what are people's experience with all this stuff. And getting that opportunity, I can honestly say it's been the best thing for me to transition out of what I was doing. I do miss bedside clinical care quite a bit. But really in the sleep arena, So I'm sure if you're doing HD and all that, I don't know how you guys had it during COVID, but I mean, the whole first round, we kept on doing that thing that you do where you're like, oh, we need to restrict fluids. And I never really agreed with it. I was like, no, these people are like sweating and febrile. They probably need more fluids, but because of their hypoxemia, we're trying to do that, like minimize fluids thing. And inevitably with like a row of people with renal failure, I'm like, yeah, could have predicted that happening. Then we got smarter a bit,
I mean, a bit, we
tend
were
to
like
get
the
smarter.
epicenter in Northeast, and we were giving people azithromycin, we were giving them vitamin C, we were giving them magnesium.
Plaquenil.
We were giving Plaquenil for a short period of time, ivermectin, Kaletra, which is an old HIV drug. So we definitely learned a lot through that. But by the way, that was an excellent intro, I think, to the start of our podcast. So we are going to start the show by Clinton.
And once again, you have to fix your collar. Fix it. It's crooked.
Come on. Why are you paying attention to my collar?
And look at you nerds with your stethoscopes around your neck.
I know.
So,
actually,
and the
classic
thing is,
medicine doctors, right? The surgeons never have that, and the medical. Did you guys ever joke about that in training?
Of course.
It was always
we
like
joke
the
about it with
surgeons are like,
ID guys,
take it off
they
your
never
neck.
use it.
I'm not even sure Clinton knows how to use his anymore. Do you use it? It's like a Fisher
I
Price.
listen to S1 and S2.
It's like a yellow one.
S1 and S2. You don't hear that S4?
I do right side maneuvers in all my patients. Thank you.
Are you done, Dr. Suraj?
I'm done. Go for it.
Infectious disease extraordinaire. I'm Dr. Clenton Coleman. Welcome back to Recommended Daily Dose. We have an amazing guest today, Dr. Alison Kole. She's board certified sleep, pulmonary, and critical care physician. She says she is a chronic insomniac turned sleep biohacker. That sounds cool.
Oh, I like that.
She's also the host of a podcast, Sleep is My Waking Passion. Welcome to the show.
Welcome.
Thank you so much for having me. I was blissfully honored that you guys remembered who the heck I was and invited me to come on. I think it's super cool to chat about all things medicine. And And it's so refreshing to see other people kind of venturing out and doing other stuff besides what we do during the day. Very cool stuff.
No, you're right. And, we want to know about your story, but, you hit the nail on the head there with doing other things. I think this idea of side, and we talk about it all the time, side gigs, entrepreneurship, we do consulting, we do some media stuff. And so tell us a little bit about your journey. I think you went to Columbia, right? And then from there you ended up, we actually all were fortunate to work together for a short period of time, very long ago when I had more hair.
You had hair.
And Clinton didn't have to color his, but those days are long ago.
You want to know a funny
man.
story? I'll tell you a funny story.
Actually, let her talk. It's our guest time.
No.
I want to hear the story.
She wants
Go
to
ahead.
hear this.
All right.
So when I first started getting gray hair, I had my hair and my beard. So I thought it was cool to try to dye my hair. You ever dyed your hair? And see how ridiculous you look? I look like
everyone can tell. Just
everyone knows.
You didn't.
And then
Did
it's
you get that hair club?
down.
What? Not hair club for men. What's that one? Was it hair
no,
club
you're
for men?
talking
Like
just for men.
Just for men.
That's what it was.
That was me. I use that brand actually.
I answered that question a little too fast, but yeah, I never used it. Yeah.
Oh man, I think you both look fabulous. We're aging gracefully, as they say, right?
Some more than others, yeah, but for sure. Alison, tell us what you've been up to since we saw you initially when you were at Inglewood Hospital.
Oh yeah. So, just for clarification, I went to undergrad. I was a Barnard grad. Yeah. And then I took off and I went to Tufts in Boston. And then I ended up out on the West Coast and did all my training at Cedars-Sinai, actually. And it was really thanks to Perry Young. She was a roommate of mine. And we became really tight in med school. And she was from SoCal. So it was a completely spontaneous conversation with her. She encouraged me to go out there and interview. I interviewed and I was like, oh my goodness, it's sunny all the time. And I'm across the street from a mall. And I just... I saw a celebrity kind of yelling at a paparazzi and I was like, this is magical. I need to come here. And they just by complete happenstance, like happened to get in. And so I was this Jersey transplant in Los Angeles and I was there all through internal medicine, Pulm Crit.
Okay.
And then I came back. My dad had some health issues at that time. So I came back, took a job with someone. I really wanted, I don't know if you guys ever experienced this, but like when I first finished Pulm Crit fellowship, at least I kind of felt like that imposter a little bit. Like I'm passing things. I'm in this point that I'm like, now ready to be a very real
thing. I think some people feel that their whole careers, it's or different.
I felt that probably the first 5, almost 10 years. Like
10 years.
You have to put enough time in to feel validated, right?
No,
I really felt insecure. Like I was like, can I really do this as an attending? And so I was like, all right, they had offered me an actual sleep position in the fellowship program because they were saying, listen, if you're interested, come stay. At that time, it was Silverio Santiago. He retired. We used to call him Papa Santiago. So Papa Santiago had encouraged me to do it. And like my dad, I just was like, you know what, I need to be around my family right now. And I need to feel like I could actually do this as an attending. So I found a job in the Morristown area and I worked with a gentleman who had split off from his group. And, first and foremost, that's kind of a hint, like, why did this person suddenly break off from their group? And what I came to realize is that just the model of medicine was a little bit more progressive in California. They had like Kaiser models and they were more organized and things were like sort of groups were starting to form and it was less of the individual private practitioner.
Yeah, Jersey for sure is kind of the last, and that's changing too now, but had for a long time was one of the last bastions of small independent practices, right? So.
Exactly. So at that time, this was before everything started getting organized. So he had gone out on his own. He had hired someone. He needed someone else. So I interviewed with him. He seemed like a nice person. And I was like, I was new. I was like, all right, let me try this out. So I had a 2-year contract, which I honored. And this person, really was a pulmonologist. But what I realized was that my role really was to allow him to do a lot more sleep medicine. And we were going to take over the Pulm Crit responsibilities. And at that time, they didn't have closed ICUs or anything. So, it was, again, a very traditional old school way things used to run and how Jersey ran for a long time after a lot of parts of the country weren't running that way anymore. And, I was on call like 50% of a month and it was not a situation that was sustainable.
It was, yeah, exactly.
Yeah. And I just was like, this is really not what I want to do forever. And literally I made a phone call And I called up Papa S. I said, Papa Santiago. Of course, they didn't call him that. But I was like, still
Papa.
very like, talk to me about sleep. The one thing I have to say is, as challenging a role as that first job was, I learned a lot. And I also came to appreciate sleep medicine on a level I didn't really understand before. And it was almost like that, okay, now I figured out I could be a pulmonologist. I figured out I could do critical care. But the sleep piece was like this nebulous, like, oh, I just don't know enough about it. And we did it in our fellowship. We had a sleep clinic and everything. But you know how it is, like, until you get that in-depth knowledge or you can really spend time on it, you just don't know.
Plus, the public awareness wasn't there, right? I feel like sleep is like all the rage these days. And I mean,
Yeah.
in a very positive way, but 10 years ago, people didn't really understand how important.
So true. And it was like all sleep was sleep apnea too. And you're kind of like, it's not really, but I didn't know what to look for, So literally a phone call changed my life. He's like, can you be here in June? And I was like, yes. And I was just like, I'm peacing out. I'm going to do a sleep fellowship. And it was glorious. And for multiple reasons. Yes, I was learning sleep and I was really into it. And I literally just came back this weekend from the American Academy of Sleep Medicine Sleep Disruptors meeting. And it was really a reunion. I was there with Vicente Santiago and Val Cacho. Hey, guys. And those are two of my sleep co-fellows. And I've not stopped talking to them since we were in sleep fellowship. So for over a decade, we've had this like text stream where we're sharing ideas, going back and forth, just being in each other's lives. So I met some really cool people. But for me, yes, aside from the sleep, you have to understand, think about this. For the first time for an entire year, the only call I really took was self-imposed because I wanted to keep up my critical care skills. So I did some moonlighting at another hospital just so I could, be teaching and spending time with residents and fellows and still keeping that skill set. That's it. I did nothing for a year other than sleep fellowship. It was like a 9-to-5 gig, basically.
Do you find it weird that critical care and sleep are like they're hand in hand? I mean, I understand why pulmonologists go into sleep medicine, but it seems like polar opposites, right? Critical care, you're dealing with a whole different level of acuity. And then you have to like slow it down to treat someone with a sleep disorder.
And to piggyback on that, can you do sleep fellowship like in primary care, or you have to do
neurologists? I know some neurologists who do sleep.
Right.
Clinton, you're absolutely right. So internal medicine sleep, now family practice sleep, neurology sleep, there's psych sleep. I even met a gentleman who is cardiology sleep. So now there's a lot. It's like a subspecialty within specialty, or you don't even have to do a specialty to do it. I think there's certain things that certain specialties, if you subspecialize in sleep, you bring to the table. Like psych is very strong in the cognitive behavioral therapy. They understand the intimate relationship between your mood and that. I think that neurologists bring to the table that expertise in EEG reading. They often, because a lot of central disorders of hypersomnolence, I alluded to them, narcolepsy and idiopathic hypersomnia, are things that may come to a neurologist's attention sooner before a pulmonologist. There is utility to that. When you're talking about advanced modes of ventilation, being really comfortable with anything from CPAP, APAP, BiPAP, ASV, non-invasive ventilators. These are things that pulmonologists deal with all the time. So that, neuromuscular disease with respiratory muscle weakness. So I think we all lend ourselves to a certain skill set. And that's one of the things I really love about sleep, is that it kind of, there's this intersection amongst specialties even, and we all sleep. Plus, Clinton, you had alluded to it. It's very different than critical care, right? So the time I did in sleep fellowship actually just gave me this break from like I said, I was on call 50% of a month. Yeah. Like, you're incredibly busy. There's no time to breathe. And sometimes you need that space where you actually have time to like breathe, reflect, figure out what you want to do in the next stages of your life. And some people are not into that slowness. Sleep may not be interesting to them. I found it fascinating. And I also, honestly, it was really rewarding to help someone with a sleep disorder. And you're like, I don't have to talk to you about like cancer or, end stage of life issues that occur in like the ICU, and it's not that there's any, it's all relevant is what I'm saying, but some of it's a little bit more challenging. And I just kind of liked the pat on the back, if you will.
But just remind me, after you did sleep, is that when you came back?
That is when I came back. And that is when my very first job coming out of sleep fellowship, now as a seasoned quote unquote pulmonary critical care doc, and sleep doctor was to Englewood. And that's where I met you gentlemen.
Did you drive like a white car? This is all coming back to me.
Oh my goodness.
I have no idea why.
As
you're
memory.
Talking, as you're
weirdo.
talking,
All right.
somehow this just came back to me that, wait a minute.
I can see him in the parking lot.
We had a discussion in the
cars.
parking lot about something probably. And I remember you had this white car. I kid you. Maybe I'm making this up. Am I correct?
I still have a Ford Mustang convertible.
I knew it.
Inconvenient car to have in New Jersey in the winter.
Boy,
that was my baby.
It was all
sitting
coming
in my
back
garage right now.
Like, holy smokes! Yeah, it was all
still have it.
You know, when I first showed up at Englewood,
like
I still had the same car I had from like residency and fellowship, and they were like, "This is for attendings only." I'm like, "No, honestly, this is actually my car." I was a fellow yesterday. I'm attending today. They almost didn't let me in.
You've upgraded since.
Stop.
Yeah. But so you did pulmonary critical care, and we always talk about people because we're all probably the same stage of our careers somewhere in the middle. But what was it that? Well, tell us what you did there. I think you've done entrepreneurial things, and that's what we love. Really talking to physicians. I think anyone out there really just becomes inspiring to hear about people doing so many different things. In the old days, which wasn't that long ago, it was kind of like you come out of fellowship, you hang up a shingle, and you do the same thing for 40 years. And then
right.
And then maybe you have a little time to yourself. And I think a lot of docs don't find that professionally or personally rewarded, right? And so a lot of people are doing and getting into a lot of different things for a lot of different reasons. So tell us some of yours.
Yeah, I mean, I transitioned out of the part with Englewood, which I shared with you a little bit, because I really, had this opportunity as a person who is young and female to have an opportunity to build a sleep program. And so I took off to do that. I was like, this is the coolest thing ever. And in my mind, when I left for that job, I was like, this is my dream job. This is what I want to do. I want to run a program. I want to build it. I want to do all these cool things. And it was that way for a long time. And then you just start through your experiences. And I'm sure you guys, I'm not preaching to the choir when I say this. There's been a huge shift in just how medicine works in 10 years, 15 years, like since we started, it's been a monumental change in a very quick, short amount of time. And this is even pre-COVID. And just what the focus was, how much time you have for a patient visit, the responsibilities of, do you really have that infrastructure or that staff? You're not cherry picking these staff. When you grow a large organization, they assign you people. Some people are better than others. That means some of the work-life balance kind of goes out the window. And I found myself spending more time just seeing the patient and feeling as though I was overextending myself, and less time on program building and really figuring out interesting ways to manage an entire patient population, which is ultimately why I started out doing what I was doing. I thought I'd have that opportunity, and I didn't feel like there was really room built in to make that happen. And then COVID happened, obviously. And I call, it was all COVID did, truth be told, and at least for me, it was an accelerated process that had already been brewing. It's not like I wasn't feeling a certain way. It's just that then all of a sudden it's the Northeast. You guys know just as well as I did. I mean, my hospital, we had 100 people on ventilators. I mean, we're using ventilators that are used for MRI machines, are never geared toward an ARDS patient. I mean, we were going old school because we had no equipment. They were using the PPE. It's like the whole drama of it all, right?
We had one mask that we would have to wear.
We keep in a brown paper bag. We walk around with the mask and reuse.
It's crazy.
Bags. Yeah, it's crazy, right?
Yeah, totally. We found creative ways to just sort of survive that experience. Really snarky sense of humor, as we know. You got to laugh when you're crying inside. And a lot of really, really solid relationships were forged during that time, just amongst being in the ICU and really getting close with my ID peers and the nurses and other colleagues and everything. So there was good that came out of it, but it also, when you're thrust into the situation where, at least for me, my reflection was, these are people that never thought in a million years that this was how it was going to go down, and yet you never know when your time's going to come. And I really started to feel, for lack of a better term, a little bit selfish. I was like, I give so much of I was giving 150% to everybody else. There was nothing left for me, and maybe a fraction left even for my family. And at this time I had toddlers. So I literally had my mom being like, when are you coming home? And I'm like, when I get done. And to have little kids
Yeah.
that want to like hug mommy. And I'm like, don't touch mommy. Mommy touched COVID. Mommy needs to shower now. And just that whole, psychology.
I stayed in the basement. I'm sure Clinton did the same thing, or actually, did you work during COVID, or you actually took a little break?
I worked. We actually, in our house, we have a different wing that's
Oh,
above
different wing.
ground than I stayed
Oh,
there. So.
you were in the West Wing?
I used to pick up my scrubs in the garage before I even walked in the door. So
Yeah,
I
that
can't
was
imagine,
terrible.
my son's older, so I can't imagine having toddlers and explaining to them that,
But now we just walk around with COVID all over our clothes and
Now we're
we
like,
hug each other.
whatever.
It's okay.
understanding is a
No,
little
it's
bit
like, I'm just
different.
going to
Right,
pick my
right.
booger and wipe it on
RSV,
you.
COVID,
It's fine.
it's all the same.
But, it was just a reflection period for me. And I really, truly like came out of that going, okay, now I'm going to start advocating for myself. Now I'm noticing that whole idea that we're taught throughout our training, right? Postpone it. Don't do that. It's okay. Finish this and then you can do that. You'll be happy when, all of that, like it's the next step. It's the next step. Well, now we're attending. It's like, what's the next step? Right. So I started to advocate for myself and I started to say, listen, I think I'd like to cut my hours down. Can I focus more on things that I enjoy, like the administrative part of the sleep program? Can I build that out? And it just was my goals were not aligned with my organization. At least that was my perception. And I tried for about a year or so to try to make some of those changes once the kind of the dust settled and I no longer needed to do like as deep a COVID call situation. And I just found my personality changing. Like I felt like I didn't really enjoy patient care anymore. I felt like I was too snippy with folks. I was like, this is not me. I'm like a happy person. Like, what's happening? This is not any person that I recognize.
I'm so glad you mentioned that because that is, I think, exceedingly important. And delayed gratification. So our whole lives we're taught like just keep studying and keep working, and have fun later. And then I think all of us at some stage, became impatient, and then you start viewing patients instead of like a privilege to work with them, and instead of they're looking as like a burden, and then you realize this is really affecting your personality and your mental well-being. So we appreciate you talking about that. I mean,
I think it's really important. Yeah, I mean, and for me, like literally, I'm not even this for me. This is like I got to the point where I'd be on rounds. I'd go to the hospital. Dr. Kole's here to save the day. March in, take care of my ICU patients, do this, round, blah, blah, blah. Have a break. I would find the quietest place. They had 2 little tiny rooms. They were smaller than my bathroom. Like that's how small they were. They had a little desk with a computer, right? You'd sit in there, shut the door because it's the only way to have privacy. Sometimes I would just like spontaneously find myself crying. Other times I would just stare into space. And I'd be like, what do I want to do? Is this it? Like, is this it? Like, every time I try to make a change or advocate for myself, nobody seems to be appreciative that this is like, for me, it's a big deal to extend myself this way. I'm not a person who admits defeat. I'm trying to admit defeat here. Like, I can't do this anymore. And nobody seems to really take me seriously. And there's something to resilience. There's something to saying to yourself, I refuse to accept that this is the way it's going to be forever. I'm not happy with the situation, but I also know that there's some part of me that won't give up. I refuse to give up. But that not giving up to me was like feeling like I use the analogy of like hanging on the side of a cliff by your fingernails. Like, I'm like, how am I going to hold on here? And it was a podcast. It was the Sleep is My Waking Passion podcast. Spoke to about it with my husband. I'm like, I don't know what I need. I don't know how to make this happen. I don't know anybody else who's really doing this, or at least it felt so overwhelming that, I just didn't have time to process it all. Right. And I just decided that was what I was going to pursue. I didn't have a backup plan. I mean, podcasts aren't free, right? You got to start thinking about how you're going to, monetize or how you're going to make a living and everything. And I thought to myself, gee, this telemedicine thing is really a thing. And I've never built a program that's purely telemedicine. Do I think I could do it? Well, I don't know, but maybe I'll try. And so it was one of those things where I just decided it was time for a break. And I just needed some time to think about it. And I finished out my call cycle. I was given the opportunity to sort of really spend some quality time with the family, take a little time off, really process, take care of myself. And for those listening, that there's no shame in admitting that sometimes you talk to a therapist, sometimes you take antidepressants. These are things that really helped me, and I'm not shying away from that. We shouldn't be ashamed to talk about it in the healthcare field, so I'm going to bring it up. And, I really sort of got my head screwed on straight. And then through that experience, I was able to have time. So now I'm like searching social media. Oh, my friend Matt has a podcast. Let me talk to him. Let me reach out here. Let me do this. Let me see what's on YouTube, and just start doing research. And then the idea was born. I put very specific parameters around goals I wanted to accomplish. So that was something that I had learned early on. Like, you can't just like go into the ether and not have a plan. But sometimes when you don't know what the plan is, it's helpful to brainstorm and say, what am I hoping to accomplish in the next month, or in the next 3 months, or in the next 6 months, or in the next year?
Did you do this all on your own? I hear a lot about like career coaches, even physicians, hiring or utilizing career coaches. Like, it doesn't normally in our psyche and how we think about, like, and I made it to the top here. I'm triple board certified, but now there could be more. I don't have to be stuck where I am now. But because I feel like what you did takes a lot of courage, and a lot of physicians, I feel like, okay, well, I have a job now and I have a family. And so how did you did you utilize any help, or was this all retrospective, inward thinking and inward looking, or did you utilize any kind of external forces?
I would say the external forces, believe me, when you start doing things like this, or you start trolling around, the internet knows things. So they start like populating you with messages.
Yeah.
I did go through a program run by a woman called Julie Santiago. And it was really about, what struck me was, it was basically like, are you a career woman who's burning out? Like, have you burnt out? What does that look like? How do you address it? So I really went through a burnout program, but it wasn't geared toward physicians or anything. It was just general. It was very expensive, but I felt like it was an investment within myself. And that's what I chose to do. And it does help that I, have a husband. So I'm like, hey, guess what? Girlfriend's taking a break. You could be paying the bills more. Thank you. So it did help to have someone that I felt like I had a safety net. Like there was somebody else bringing income in. I didn't have to do it all on my own. But that program is where I learned to really think about, first of all, just to heal first, to give myself that time to heal and not just jump into something because I wanted to escape my feelings, which I think sometimes if you're have a tendency to be a go-getter and you feel like you got to accomplish things. And then sometimes you just don't get a chance to process your emotions all that well. And I think I've been going heavy pretty much my entire life. And it was just time to be like, oh, right, a little growing up to do, just in terms of healing how I felt and how I got to my place. And actually, to be honest with you, also taking ownership, like how did I contribute? Like I didn't have good boundaries. I kept saying yes to everything when I should have said no. Like just little things that we don't think about, but taking ownership of where I fit into the paradigm. And, I tell people all the time, I'm like, listen, create the boundaries now, because it's really hard when you don't have any to start putting guardrails around yourself, because people don't like it. They want the old version of you. That's what they're used to. People don't like change.
They're used to someone who's saying, I'll take that. I'll be on that committee. I'll take this responsibility. I'll teach students. I'll teach the residents. Right, I hear you. So that's
there's an art form to saying no. So I'm glad that you found it. It looks like you found your passion. I want to get into the podcast.
Yeah, please.
Because I think for you, it probably serves more than one purpose, as far as an outlet for you and creative outlet, but also serves as like an education form. Because I know as a primary care doctor, I'm pretty bad at sleep and discussing sleep. And like if someone says I have trouble sleeping, I'm like, have you tried melatonin? And that's where it stops. Right. So we really don't learn it very well in medical school. But it is really important for, optimizing health and stuff. So let's get into that. Like, what do you...
Let's say a middle-aged man who you may have just met.
Middle-aged,
comes to you and tells you he snores a little bit at night. He's been told by his wife, and he wakes up cranky a little bit. And when he wakes up at night, this is a common issue, right? So so A, how do you get the word out there? And then B, give us some sleep tips and pearls, if you will, because as I've gotten, past the 40 and 45-year-old threshold, man, I am really realizing I don't sleep like I used to. And I'm realizing it more and more, and like anyone else out there, how important sleep is for everything, right? Blood pressure, whatever it is. So tell me.
There's so much to unpack here. So I'll do my best. But You
Thank
know,
you.
Clinton, you commented that we don't get a lot of this education. We totally don't. And it almost seems like, in a way, it's like they don't want you to know how important sleep is, because when you're going through med school, going through
Or
residency
maybe
and
we
stuff,
don't
it kind
know.
of feels
Maybe
like, they
maybe
don't
we
want you
don't
to know
know, I
that.
guess.
What's that?
I said maybe we just don't know how important it is. It seems like there's been I think Suraj alluded to this, a revolution in sleep and sleep education.
Correct. So I think, first of all, it needs to be emphasized more in medical schools, which it was not. And again, I think part of it was that our sleep was never prioritized when we were in training. It was
true.
like, and if you're left in the dark, you can't focus on it if you
It was
don't
a
know it's
badge of
important
honor,
to
right?
focus
That
on.
I worked all night, and
Exactly.
48 hours straight.
I was before the 80-hour work week, so we didn't have night float. It was you work all day, you work all night, you work the next day, and maybe you leave whenever you're done. And it was a badge of honor that I had half an hour of sleep, I had an hour of sleep.
Right. Exactly. So what we're coming to find, just in terms of like the literature on even sleep deprivation, is that it really affects multiple organ systems.
Right.
And we're also learning from circadian science that all of our organ systems actually have somewhat of a circadian approach. So even like our digestion, when you're asleep, it's supposed to be restorative. So we see, this is why when we wake up and we're not sleeping well, we may have cognitive impairment. Our immune system doesn't function as well. And then there's a slew of cardiovascular risk associated, right? We have high blood pressure, stroke, myocardial infarction, congestive heart failure, atrial fibrillation, so cardiac arrhythmias. So there's a lot of things that are not good if we're really not getting, consistent
Asking
sleep.
for a friend, how about the effects on the bladder?
So that's very interesting, because
How many
what
times
we
do you wake
know
up to
is
pee?
that
I know Dr. Uri is a real thing, right? So
that is a real thing.
Yeah.
I wake up
And,
twice.
how
Thank you
I've
for that.
experienced, how I teach it, and forgive me if it's not perfect science, but how I understand it basically is that, if you are having this, particularly if it's associated with sleep disordered breathing, sleep apnea, which I'm about to talk to you about in a second, about a quarter of men at all lifetime are going to be at increased risk. Women, it's about 9% premenopausal. It goes up to the same risk as men as they're postmenopausal. So right out the gate, you got a 25% chance roughly of developing sleep apnea over the course of your lifetime. But for peeing, for example, what we see is that
is that across all people? So because I'm learning more and more, we were always taught that someone with a bull neck and very thick or wide neck circumference, but I feel like more and more, again, asking for a friend, some of us that are of normal BMI and have normal neck circumferences.
Your BMI is not normal.
I'm
on,
quoting
have you seen me
population data. So I'm just saying,
25%.
generally speaking, across the population. So if you were looking, it's the most recent study that was looking at the just general global worldwide assessment of sleep apnea. And this is mild all the way to severe. So we're talking about even more mild cases. It's estimated that 1 billion people in the world have sleep apnea. And what we know is that phenotypes, right? You're talking about a phenotype. Obese, snow neck, looks like, a snowman, if you will, a bowling ball on top of a bigger bowling ball kind of situation. Thick neck, as you described. Some of those very sleeping all the time, snoring, stopping breathing, gasping, all those typical sort of things that we look at for sleep apnea. That is just but one phenotype. That's just one type of patient. But especially if you're getting into South Asian, African American, Hispanic, when you're talking about the underserved, the minority population, there's significant sleep apnea populations. In fact, it's higher than Caucasians when compared. And what we know is that, and I'll tell you this from personal experience, plus we know, people may not, the neck circumference issue that we always talk about with like stop bang, and that's like one of the common ways that we screen for sleep apnea, and I'm sure, Clenton, you probably have to do this for all your people that are going in surgeries and stuff. But like the stop bang questionnaire, the neck size may be completely inaccurate. If you're female, premenopausal versus postmenopausal makes a difference. You can be thin. Females don't even have to snore. They may still have sleep disordered breathing. Women are more commonly going to say, hey, I have insomnia, I have difficulty sleeping than men are. Doesn't mean that men won't complain of insomnia, but it's more common in the ladies. Sometimes it has to do with your jaw. Sometimes it's really a family history thing. I've caught a ton of people who are, sort of a normal body mass index, may not have a big neck, may not obviously have it, but, mom has it, dad, grandpa, they didn't check back then, but grandpa snored. They may have had some of the other issues, hypertension, high cholesterol, diabetes. Those are some really common things that we associated with sleep apnea. And I'll test them and we will find significant sleep apnea. I mean, I've had people that soaking wet, they've got to be, barely 100 pounds and be a thin Asian male, not a super small jaw. They look okay from the outside. Boom, terrible sleep apnea. So you just never know. It's one of those things. Like if you're going to go back to that patient that you mentioned, that middle-aged patient, just asking, who may get up a couple times to pee at night, for example, if you were having obstructive events at night, if you have untreated sleep apnea, right? What's happening? Well, it's a relaxation of the area. This is the most common type of sleep apnea. So I'm kind of generalizing to speak of obstructive sleep apnea, just call it sleep apnea. But if you're having upper airway relaxation, right? And that obstruction can be multiple places, anywhere from nasal all the way back. Commonly, it's going to be the tongue rolling back, closing off the airway, but that's not the whole piece of the puzzle. Okay. So if you have an upper airway relaxation muscle issue, right? And even if it doesn't close off completely, if you're having at least a 3% drop in your oxygen levels, that your body may, and again, I would imagine that you might see it more profoundly in someone who's more severe drops in oxygen levels, right? Not what we're coming to learn is that your airway could close off 30 times an hour. That's severe sleep apnea. Maybe your O2 sat nadir, your lowest oxygen saturation point's 90%. Well, is that the same as a person who drops to 60% and has an AHI of 30? I would argue no. I think those are two phenotypes that we're dealing with. Somebody is getting much more hypoxemic, and I think that might have better, worse implications potentially. That's what we're looking. I mean, there may be data. I can't tell you that I know for sure, but I know these are things that are actively being studied. Like,
But when most of us think of sleep apnea as far as severity, we think of apneic episodes. We don't think of as a lay. Not a lay person, but
exactly.
Not as an expert. We think of how many times you stop breathing. You don't think of the hypoxia associated with it.
So, and these are the things that we're actively studying in the sleep medicine world. And I'm fascinated by, because I've always suspected, I'm like, it seems like that person with the real low oxygen levels there's something more severe about that person than the other person. And that may have clinical significance. And they're going to look into that, because I do think drops in oxygen levels, and also what's your heart rate response to that? Some people have a bigger heart rate response, other people not. It implies that there's a little bit more, autonomic sympathetic nervous system activation, which might be worse for you in the long run.
And I think we downplay the long-term cardiac effects, right? I tend to see a lot of sleep apnea. I wouldn't say see a lot of sleep apnea, but part of the secondary work of hypertension is, ruling out sleep apnea. So that's where I run into all these patients who look like normal people have underlying sleep apnea. So, and
I think it's worth an exploration. I really do. I'm like, because it's low hanging fruit. Like, it's like, okay, you've got a problem with your breathing, let's fix it, as opposed to adding multiple, because, and sometimes that's where I catch them, is they're on 3 medications for their blood pressure already. And I'm like, okay. And they're like coming to me because, it's not really working. And, I don't think they have renal artery stenosis or whatever workups happen in the backstory to figure that out. You're just sitting there going, okay, well, what else is it? But wouldn't it be nice if I see them from the get-go, or even ideally, if we could figure out, are they having these subtle symptoms? If there was a way, and this is what they're actively studying, if there was a way to predict someone's going to be at a higher risk for high blood pressure, based on something, they haven't developed it yet, but certain parameters that might suggest sleep apnea. I think that's really fascinating research.
Can you talk us through, like, for instance, now, like, diagnosis, and then let's for this hypothetical middle-aged male who wears nice shirts, like, and then possible treatment option. But first and foremost, are you referring patients that you would suspect to an inpatient sleep lab, or at the at-home monitoring is that adequate for a diagnosis of OSA?
That is a great question. So I do want to answer. You asked about nocturia. We didn't quite get to it, so I want to answer that first. Sure. But the nocturia, the frequency of urination, if you're having big drops in your oxygen levels, what happens is that's a stress on the heart, right? The heart's going to sense that it's there's hypoxemia there. So it's almost like it sort of releases hormones that make you have to pee. So that's just where that's my cursory understanding, is it basically it's almost like a transient heart failure piece. It's like, hey, you need to, it's almost like it's your body telling you, like, to have a diuretic effect, basically. And that wakes you up and you have to pee. Yeah. So it's crazy when you think about stuff like that. But getting back to your point, in terms of how we would diagnose it. So, there is the doctor answer, and then there is what really rules the world, which is an insurance answer. So we're getting a bit into the weeds here, in my opinion, because which I don't mind doing, but it is, and again, this is just a Dr. Kole opinion, but I'm very concerned that insurance does a bit too much dictating of how we actually do our jobs. I do understand from the flip side, from a utilization management perspective, that if a physician is incentivized to have their own lab and fill that lab with tons of patients, and the testing that they're offering, the in-lab sleep study, is very expensive, and they're just milling people through the sleep lab, there is a profit to be made. And so you do need people who say, is this an appropriate use of limited resources? So there is an argument to be made on that side, and I'm sure that's where the insurance plans would come in. But basically, if I had to wave a magic wand, what I'm looking at is, if I really think you're low probability of having sleep apnea, theoretically, I should be allowed to put you in the sleep lab. And based on that, because the sleep lab is going to really eliminate some of the downfalls of home sleep testing, which is inaccuracy, particularly for people who may have mild disease. It's really the gold standard. Okay. So I'd rather have an in-lab, but many insurance plans may say, listen, if you suspect sleep apnea, they have to have a home test. And so, the home tests really vary in accuracy, but the accuracy goes down when you're talking about very mild sleep apnea, and there can be slight night-to-night variability. For example, if I gave you a beer and told you to go to sleep and you fell asleep on your back, I may have a certain number. If you are sober and sleeping on your side, I may get a different result. So there are some dependencies here, and you can tease some of that information out if you're not doing a home test, like if you're actually in the lab. The flip side of the lab is then I hook you up to like 30 electrodes. There's all sorts of bands and wires all over you, and I'm telling you to go to sleep with someone staring at you that you've never met before. That's called the first night effect, and that's real. So some people might not do well with that. So there's a little bit of give and take here about what we need to do. But generally speaking, if I was suspicious, I would start off with a home test, because most insurance plans will let me pass go and do a home sleep study. That may change in the future, but that's where we're at right now. And then if it was negative and I really was concerned, I would pursue further testing. Ideally, everyone would get a second test. But, I really have that discussion with the patient, because, for example, for insomnia, difficulty sleeping, either difficulty falling asleep or difficulty maintaining sleep, when I'm looking at that, it really kind of depends on what description you're giving. But again, like I said, some people, they're just going to say, well, I have trouble sleeping, doc, but they're going to look thin. They're going to have a good airway. They're going to have a Malampati 1 airway. That's their only complaint. Oh, my husband never says I snore. I don't know what you're talking about. I feel okay. I don't know why. I'm just generally not able to sleep at night. This is a classic thin woman going through menopause. I can't tell you how many people, folks of these I've seen. And I learned my lesson, because I actually had a thin woman, and I was like, I really don't think this lady needs a sleep study. And I am telling you, her dentist did a sleep study and found that she had sleep apnea, gave her an oral appliance.
I want to get into
doing
that
much better.
because how does someone who specializes in sleep medicine as a pulmonologist feel about dentists and
sleep
ENTs,
and things like that?
Well, that's another,
treating it with jaw devices. And
I actually am very, very supportive of it, because there's like over 10 years worth of literature that really supports that it could be helpful. Is it going to work in every patient? No. And it depends on the severity of the patient. If I don't really think I'm going to get a good response, let's say they have an AHI of 100, if I reduce you by 50%, which is the average, right? If I give you an AHI of 50, I guess that's better, but it's still pretty bad. Like, what am I doing? You're still severe, right? Or I may have that patient who's like, doc, listen, I really want to get an oral appliance. And I'm like, yes, but your neck is like 24 inches. And like moving your jaw forward, is that really going to take care of the problem? But you'd be surprised. There are some people, even in the severe category, who may get a decent response from it. In terms of like dentists just ordering tests willy-nilly, I believe it's really important for us to collaborate. There is a role for collaboration between dentists and sleep physicians. In fact, I'd like to see more of that, because especially for your more mild patients, you may really have a shot at getting some pretty good control of their disease, and they may not want to wear a mask. Masks, it really depends on who you look at, which institution, in terms of efficacy, because it can be all over the board and it's generally pretty bad. I'd say it probably works in about 60% of patients. And again, it also depends on, are you looking at 1 year out or 5 years out? Because that compliance may fall considerably. And we're looking at ways to predict who's going to be more compliant with CPAP than others, you know.
And the machines are getting smaller and
days.
Supposedly more comfortable, right? Unless
that is true. I mean, they have portable units now. Those are generally not covered by insurance. But if you have a deeper pockets than some, you can spend like, I don't know, $900-ish and you can get, you know, a travel unit. And the masks they have a lot of innovation in terms of masks. So lots of different styles and everything.
What about this pacemaker that they can insert?
You're talking about the Inspire. Yeah. Right now there's Inspire therapy for obstructive sleep apnea. There is a different device called Remedy for central sleep apnea. We're not going to get into the weeds with that. It's very new. But the Inspire therapy has been out. Now it's probably been around a decade or so. I remember back in Englewood, I was speaking to a thoracic surgeon who asked me about it. And at that time, they were very, very strict with who they rolled out Inspire therapy to, meaning now you can get trained, you can become an Inspire center. It's a lot easier than it was a decade ago. But that's viable for patients with severe sleep apnea. It used to be that there was very specific criteria, like you couldn't really be too obese. Like I think you had a body mass index of like 32 or below. Sometimes it was 35 or below based on some European data. Your AHI had a range. I think the cap was around 65. In terms of severity. And they would do something called a drug-induced sleep endoscopy. That's a procedure where they put you to sleep with anesthesia. They're giving you some Michael Jackson juice, a little propofol, light sedation. So you're not stopping breathing. They're just light sedation, but they're mimicking what you might do with sleep, right? You're relaxing the muscles and you're watching how the airway closes. And if it was felt that your airway really demonstrates that the tongue is really rolling back and kind of closing off your airway, then you'd be an appropriate candidate. The rules are looser now. You can have a higher BMI. I think the AHI now is like up to 100. I'd like to see some outcomes data. I'm sure they have them because the FDA approved them changing this protocol. I'd like to see if it still is effective for patients who have some of those who are really on the edges of being very, very severe. But at the same time, it's just kind of like, you know, use something if you can. The battery life is around 11 years. It's, you know, it's a smaller device. I actually show and tell time. I'm telling you, I'm a huge nerd. Here you go. This is what it looks like. I'm holding it in my hand. Okay.
Cool.
But that goes in a pacemaker pocket, and it for the right patient, it can be very efficacious. Like we see, the goal here is to get them in the mild range. Really, that's where they got positive data. But if you get them to, it's possible to resolve sleep apnea in the right patient too. So it's definitely something. I was one of the folks that helped to start the Inspire program at my previous organization. I felt so strongly it was necessary, and people are going to go and get it anyway. So you may as well jump on the train and see if we can keep those patients in house.
And what about like less invasive measures or over-the-counter stuff like nasal strips? I always hear this catchy thing on the radio, a Zipa or something, you know.
Oh, okay.
These type of things.
All right. So I would say, okay, so the Zipa, God, I hope these companies don't start hating on me.
Blame me or blame Clinton, no problem.
But the Zipa, I just have personally not had any patients really be happy about that particular product. So I would say it wouldn't be something I'd highly recommend. That is feedback from patients, Zipa people. Okay. That's not my personal opinion. I've not used it.
For their marketing purposes, they have a great jingle. So I mean, you know.
Yeah, they do. I agree. Yeah. And then there's something called the Snore RX. My friend, Dr. Val, turned me on to that. And I've used that for some patients. The key with some of the over-the-counter devices, they basically just move your jaw forward a little bit, right? But a lot of them, like the Snore RX, to use for an example, it literally it's like a device, it's a boil and bite device. You make your own mold, essentially, and then you adjust it. So you kind of click it forward, and then it keeps your bottom jaw forward. Just in a little bit. It's not going to be as severe, let's say, as what you'd get with a dentist. It's not as, you know, molded to your teeth or as small. It's a little bit bulkier device.
Sure.
But they can be okay in a certain patient. But if you grind your teeth, I say be very careful and talk to your dentist, because remember, that's a lateral movement, right? Bruxism, you're grinding your teeth. Yeah. A lot of these over-the-counter devices don't allow for that movement. So if you're moving your jaw forward, but it's fixed, you're kind of like grinding anyway. You could actually some people felt that their teeth got loose and stuff. So it could be doing some damage. So you just got to be careful. But in the right patient, it could be helpful in helping with snoring, just keeping your jaw in a more optimal position. The Breathe Right strips, my husband uses them. I don't know if I'm allowed to talk about that, but he does.
No, go. Well, then fine. Don't talk about him. Talk about the hypothetical male. who was considering buying some the other day on Amazon.
Yeah. So he has a little nasal valve incompetence, meaning that if you sniff, sometimes your nostrils kind of collapse in. That's an indicator the little valve in your nose may not be working properly. Oh, you have it. I totally just saw it. Yeah.
Oh my God.
Your nose collapse. Yeah, totally.
That's a party trick.
If you think about stenting open the nose, right? You're just flailing, you're just trying to keep the passage open. If you could breathe better through your nose, that tends to reduce upper airway resistance a little bit. It's like a built-in humidifier, if you will, right? You got the little hairs and the cilia and all that. So that helps you breathe a little bit better if you can breathe through your nose. It's just less upper airway resistance. It tends to be beneficial to you to breathe through your nose. So in that case, it could be helpful. And I know if he could breathe through his nose and he sleeps on his side, we're good to go. So that's all we do in my house.
You mentioned sleeping on your side. So that's part of I think the last part you want to talk about was sleep hygiene. But do you recommend that people sleep on the side? Do you recommend like pillows so they're staying on their side and they'll fall back?
I think ultimately a lot of people kind of know, like, hey, my significant other says that if I'm on my side, I seem to be okay. I always like to check. I want to know because keep in mind, it's very difficult to stay in one position for 8 hours. Like I start off on my right side. My husband tells me all the time I end up on my back. I have no clue. I'm sleeping, right? Yeah, but I do end up on my back. It's very difficult. Plus, people who stay on one side, they often complain of shoulder discomfort. So they make these different gadgets so that, like, if you roll onto your back, some of them will jiggle. There's one called the Night Balance from Respironics, where it kind of vibrate to remind you to move over to your side without bothering you. They make belts to keep you in one position. Can you imagine strapping something to your back? I have recommended it. And I had a patient who was blind, legally blind, and he couldn't really use any of the other gadgets. So he used a belt to keep him on his side. It worked really well for him. He used that in addition to a CPAP. I would really, if somebody's really complaining, I want to test them and really see what's my hypothesis. Are they better on their side? And sometimes I've proved. I had a patient who really, we did side therapy and oral appliance. Boom, sleep apnea went away. And he couldn't tolerate a mask. That's what we did. And it worked. So we stuck with it. So it's different strokes for different folks, basically. And that's what I really like about sleep too, is we're moving in a direction to try to get as personalized as we can. And remember, everybody cares about their sleep now, right? You said it in the beginning. Yeah. So we're doing all these like commercial devices, right? You have your Oura Ring and your your Fitbit and your Apple Watch and all these parameters. And when you think about it, these devices are really collecting a lot of data. So people are going in, it's being depersonalized, and then they're actually trying to analyze data from millions of people to establish any patterns that we see that might be helpful in managing people and maybe preventing disease in the future. So very exciting.
How do you approach as a insomniac and biohacker? How do you approach insomnia? I mean, I have the whole sleep hygiene and,
I need, that's a loaded question because sleep hygiene alone is not going to work. Okay. But in 2 minutes, what I would tell you is
it's not going to work.
Focus on your behaviors. A regular wake up time is huge. 7 days a week, regular wake up time. Go to bed when you're
7 days a week. I can't sleep 7 days a week.
Keep basically establish your routine. It is so helpful.
I
got into my routine with my kids. So
should your routine be looking at your phone in the middle of the night? And I'm guessing no, right?
I started reading Miracle Morning. Have you heard about that book?
No. I have not. Should I be checking that out?
Yeah, it's good. It's I'm reading the audio version, obviously.
Okay. Me too. When I read, it's always an audio book. I always had trouble
waking up. I mean, I could not wake up, and I wake up tired and stuff like that. So it's more about, being productive in the morning, how to wake up properly and just being productive and active.
Like being thankful for your friends and if you're a co-host, your podcast co-host, right? And just really
thankfulness goes a long way.
Yeah, I tell him every day,
stress reduction.
You should be thankful he knows me every day.
Well, part of it is, you're journaling and you're waking up being grateful for something and planning out your day. And it's done. I did it for a good week. I'm trying to get back onto it, but it's really helpful to get good sleep and wake up. You feel like a person.
What is, we're hitting you up with those random questions, but that's great. What's the optimum temperature a bedroom should be for sleep?
Shoot. There is some data on this. I want to say that it's 68 degrees, but we have it at 71 in my house.
68 is nice. I like it cooler. Yeah. Okay.
I hate it cold.
Yeah. And they also, if you have a bed partner who disagrees, you can actually get a heated or you can get a cooling or heated like mattress cover, and they'll change the temperature so that a person who needs cooler can just kind of cool themselves and someone who needs it warmer. Like you could compromise is what I'm saying.
It's funny. This is less about our audience and more about us now.
This is
We're
really
talking
about us, so-
waking up to pee.
Well,
See, this
I
is
would like to
impromptu
think that
sleep
the temperature-
consultation. There you go.
I would like to think our audience has the same questions. And so, and I think we could talk to you forever. We're going to have you back on, but how about one last question, which is what about a weighted blanket? I didn't say a teddy bear, but a weighted blanket. I've heard that these things are now being, and my wife
have one.
try it, and I have to tell you, I find it very useful. It's almost like cocooning yourself, having these weighted blankets in the winter. Any thoughts?
There's real data that supports it, because when you think about it, we have these receptors on our skin and they kind of sense pressure, and that can have a calming effect. I actually researched this because I was a gentleman from Quiet Mind reached out to me. That's a weighted pillow that he designed. And he's like, hey, I want you to check this out. I'm like, oh, this is kind of quirky. Okay, cool. I'm into new gadgets. Let me check it out. And he designed it. He wanted to see about sleep because he found that he was sleeping better at ADHD. I use it to kind of calm my kids down. And when I meditate, I put it on my lap. And I do find it somehow that connection helps, like it's almost like a physical sensation that helps keep me in the present, as opposed to my mind going like 1,000 different places. So I found it helpful for that. The weighted blanket, though, for people of difficulty sleeping, as long as you're not too hot underneath that, it can be very helpful. Yeah, it can. There's actual data that supports it.
I appreciate that.
We could talk to you forever. This is fun. I think we're going to have like a weekly episode.
No, this hypothetical middle-aged guy really has gotten a lot of questions answered. So
there you go. I think there's a home sleep apnea test in the future for this hypothetical middle-aged guy. That's what I would do.
I think
would.
He's calling your office tomorrow.
Yeah, just to finish up, just so you're aware of what I'm doing now. So I did start a sleep telemedicine program. And because I'm not part of a large group anymore and I'm just on my own, I partnered with a mental health company called Oak Health Center. And it was just through my relationships with folks that I still know out in California. So they're based in California, but I always kept my California medical license all these years. So California, New Jersey, now I have one in Georgia, New York. What I will tell you in full transparency is that I'm a direct specialty care. So people can submit to get reimbursed from their insurance, but I don't take insurance because you know what? We tried negotiating with Aetna. They wanted to pay me $10. $10.
No, sure.
It's not gas money.
Dude.
In California,
seriously? It's crazy. Well, I mean,
That's
it's just there's no negotiating
burger
power. Yeah. I mean, but that's the situation that we're in medicine. It's kind of messed up.
It is, and a lot of talented people are going this route. And you explained in the beginning of why, and there's the idea, and this is for another podcast, but moral injury in medicine and really, the old way of thinking that we have to do everything for our patients at the expense of our own mental well-being, and that's just not conducive for a long-term career. So we really appreciate you sharing your journey. Can you tell us a little bit about where people might find you, our listeners, on social media, LinkedIn, websites, etc.?
As of today, I actually launched a website. There are going to be more blog posts, and it's going to be built out over time. But it's sort of my website person felt that we were ready to go live, and I'm really proud of it. And you can get more information on askthesleepmd.com, because my middle name is Sung Hee. So askthesleepmd.com. And you can also go to oak.care/sleep. I do offer free 15-minute consultations, really just to triage where I think, I offer a lot of different services because different folks for, different, what's that
Different
term?
strokes
Anyway,
for different
strokes
folks.
for different folks. Yes, I love that show.
Great TV show.
The world don't move to beat just one drum.
So in other words, like if you're kind of curious about where you fit in, do you need a shorter consult, a longer consult? I will help you out with that because I really try to practice holistic medicine and being a good steward. I don't want to just be pushing pills and stuff on people. So if I can fix you without medications, that's what I'm going to do. And that's really what my services are geared toward. But yes, I'm happy to chat with you and, you can feel free to make an appointment with me if you want to see me in real time and see me with my services. And I promise you, I will bring my A game and help you out.
And
tell me, where can people find your podcast? Like, where are you on?
Apple, Spotify, YouTube. Sleep is my waking passion.
We love it. I feel like we had our own personal, more than 15-minute evaluation by you. So we really
there you go.
Check is in the mail. $10 is in the mail.
No, but it was just so nice to reconnect after all this time, and we've all gone different journeys. But it's kind of like you come back together. So we're very happy to see you doing so well and doing such important work, because we try to always keep our podcast light and joke around, but clearly sleep and sleep disorders is a major issue, for so many people, as you alluded to, talking over potentially 1 billion people with some form of sleep apnea. So obviously it's inherently important. We hear about it more and more in the news and media and for other healthcare providers, but I still think that it's probably under studied and under publicized, not even just for the general public, but even for healthcare providers. So you're doing an extremely valuable service, and we appreciate it so much.
That's the plan. I want people to be able to be their own advocates, because for me, it took like changing a job, really focusing on work-life balance, getting a regular schedule, really decreasing that sympathetic overdrive I was in. I mean, I was like in fight or flight, if you will, like 24/7. I could not calm down. I was like an insane person. And I really needed to be a way for it to work for me. Not everybody needs that, but this is 100% the right journey for me. And but things had to, things evolve as they're meant to evolve, is kind of my philosophy. So I learned a lot. I feel incredibly blessed to have had the career I had. I'm incredibly blessed to have had the opportunities that I have. And I'm just going forward being like, listen, at the end of this life, I want to feel like I made an impact. And for me, I still enjoy one-on-one patient care, but if I can impact thousands or hundreds of thousands or millions of people by educating them, dude, that's a win. That's a win. So, that's what we're here to do. And plus it's like fun. I'm really, really enjoying this. I had such a good chat with you guys.
Oh, well, your joy and what you're doing comes out in this podcast. So we appreciate it so much. Dr. Alison Kole, thanks so much for coming on Recommend Daily Dose with myself and my illustrious sidekick, Dr. Clinton Coleman. Please don't forget to rate, subscribe, listen, check out all of Dr. Cole's, check out her podcast. We'll include the social media handles when this comes out. Until next time, be well.